Assalamu alaikum. Thank you, Dr. Shaheen, Health Asia, for giving me the opportunity to talk to you. So today I'm going to talk about a topic which is of, I think, significant importance itself, which is recurrent miscarriages or recurrent pregnancy loss. I'm also going to touch on a part on recurrent implantation also, because some of you are also involved in IVF, and there can be a pregnancy loss or non-implantation or failed implantations in them. So there's an overlap, so I'll touch base on them. So a few terminologies, and then etiological factors, and the aims of testing and how we will do the testing, and some treatment strategies, and a bit of the couple counseling. Pregnancy loss. There is difference of opinion on which to call a pregnancy loss, 20 or 24. Europeans, Americans, and Britishers, they fall for 24 weeks, while South Asians, Australians, New Zealand, and even in Japan, they fall for 20 weeks. So any loss before 20 weeks would be taken, yeah? All right, okay. Would be taken as a pregnancy loss. Now, a terminology difference of recurrent pregnancy loss and recurrent miscarriage, there's a slight difference. In recurrent miscarriages, it's when all losses have been confirmed on intrauterine miscarriages. When they are intrauterine, they would be called as recurrent miscarriages, while otherwise they will be called as recurrent pregnancy loss with the same partner. And if the woman has for first time has not had a baby before the pregnancy losses, it will be a primary, and otherwise it will be a secondary recurrent pregnancy loss. So when we are done with some terminologies, we move on to some realities. Is nearly 12 to 15% of pregnancies will be lost. So that's a baseline understanding, and some people even believe that it will be about 25% of pregnancies will be lost. So at the initial beginning, patient should be told that there is a possibility of losing a pregnancy, and one need to adjust to the circumstances. And there are a number of pregnancy losses which are never recorded, and with a period delay or something can be a miscarriage, so they are never counted. Now, only 5% of women will have miscarriages 2 or more than 2. And usually this figure is very variable, that in about 30, not more than 30% of people you will be able to explain. Rest will remain unexplained in their lifetime. So given the knowledge that we currently have. And keeping in mind the advancing age, the anatomical anomaly, and couple consideration will make a decision that when and how you will evaluate them. So debate of 3 miscarriages and beyond has been flipped, and it's more of once you have 2 miscarriages, you should evaluate, must evaluate. But if the patient is concerned and the age is advancing, and if there is any anomaly you have encountered in the uterus, it is not permissible to wait for 2 miscarriages. So even if it's a recurrent miscarriage has not happened, your evaluation should start well before that. Like if somebody has a septum, somebody has a uterine anomaly there, Overa syndrome or something, you would not wait for them to have recurrent miscarriages, you will evaluate and fix that. Now, age and number of pregnancy miscarriages are 2 independent things, and as we go on, they keep on increasing. So the younger you are, the better it is. And classically, what I said, biologically, beyond 18 and 19, nobody is getting younger. Now, for recurrent miscarriages, there's a long list which is there. Now, even the list is long, but we don't have a control much over that. And we need to understand that we cannot control all of them. There are some of these things we can control. Rest, the knowledge is still evolving before one can make a decision that things can be done for them. And I'm going to touch base on them. So, the first thing that is the most common is the chromosomal anomaly, and in which the trisomy is the one, and about 67% of them will have this. So as the age advances, this is something that is of importance. Parental chromosomal rearrangement. Now, one has to keep in mind that one does not have to do the parental karyotyping as the first go sort of a thing. It is the microarray of the product of conception that need to be done first before thinking of the karyotyping. So, which is this one. And this test is the first test that one should consider doing on the product of conception before considering that a parental karyotyping can be considered, because otherwise it will be a lot of waste of money, anxiety on it. Now, with this, maternal chromosome problems need to be clarification is required. So initially the test would be done of MCC to rule out whether there's a contamination of maternal chromosome has happened or not. If that chromosomal contamination is not there, then and then the test can be done. Similarly, the single nucleotide polymerase array is another one, but as compared to the microarray first, that's less important. For recurrent pregnancy loss couples with normal karyotyping, PGT aneuploidy is the test to go for. So if somebody has a normal karyotyping, then this would be done. Coming to anatomical ones, about 10 to 15% of population will have it, and in them, this is the sort of frequency in which you will encounter them. The point remains, whenever there is an anatomical structural abnormality, if you have not treated that anomaly, specifically of the myometrium and of the cavity, you will not have good results. Although the literature is sort of a dicey on that, ASHRAE and SIRM would say that there is not sufficient evidence to do the septum resection. There is not sufficient evidence to remove the polyp, and I'm going to talk about that. कि polyp भी remove करने की ज़रूरत नहीं है, even जो है. Nevertheless, experience as well as of other literature is available to suggest that you need to keep the cavity clean. You need to have the myometrium clean before you rule out the possibility that you can skip evaluations on them. Now, all these anomalies are there. Among them, very few will not require correction. Most of them can be corrected. If you see this, 12% of the women will have polyp in a general population. But women with subfertility, recurrent pregnancy loss, they will have an equal to less polyp there overall. One study a long time back, 2005, has shown that removing polyp has an advantage. So this is the only study which is available. All the studies which were done otherwise would say that there is no difference. In terms of leiomyoma, the fibroid which is inside the cavity need to be taken off. Any fibroid which is indenting the cavity need to go. Whether it is indenting 1 centimeter, 2 centimeter, whatever it is, indentation is there, it will affect. Myometrial, if it is a larger one, and if it is affecting the peristalsis of the uterine cavity, one should consider. Then this is a consider. Subserosal do not need to be taken out unless they are humongous and are disconvenience to the patient, and they will never cause a recurrent pregnancy loss. But somebody who has a intra-cavity lesion has to go. A big chunk is a thyroid dysfunction, big chunk. And in that, one has to see whether it is overt hypothyroidism and in which your TSH will be elevated and FT4 would be low. Subclinical, in which TSH is high, but your FT4 is normal. Then you have hyperthyroidism, in which the TSH will go low, FT may be high, or FT3 may be high. While the last one, thyroid autoimmune, in which there is an increased risk of recurrent miscarriage. Now, treatment of choice will remain levoflox. Initially, it was thought that anything above 2.5 one should treat, but now it's more of that if the levels are more than 4, then you should treat them. If anything more than 4 is there, then these are the patients who will benefit by correcting their thyroid status. Prolactin. Again, it is a very controversial and tenacious area. Anyone whose prolactin levels are high, we should try to fix those prolactin levels. And based on the cut lines which you are using in your lab, anything which is high need to be treated. And there's a good amount of patients which will benefit, which is usage. And currently, the drugs which are available, cabergoline is considered as probably the best medication to be used. And the good thing is the tablet dose is very low, 0.25. You can give it twice a week dose. 3 or 4 doses, maximum 5-6 doses are required, and the patient is fine on that. And you increase the possibility of pregnancy. PCO, again, there's a significant increased risk of recurrent miscarriage. So we need to identify and try to fix. The overlap is of obesity, insulin resistance, and high LH. Whenever a woman who has a high LH, they will have a higher risk post-possibility. And weight loss is the prime sort of a thing. If at least 5% of weight loss has achieved, they will have a good chances of avoiding a recurrent miscarriage. And metformin also plays a good role in that. Obesity is, like I have mentioned earlier, obesity per se has an independent sort of a marker, and if you are, it also has a poorer outcome. So if you maintain a healthy BMI, things are sorted out. Now, you have GPL-1s available, diets, everything is available. You can use any modality to get this fixed. Women who have recurrent miscarriages, their OGTD is also, glucose intolerance is also disturbed. Fixing that, bringing them into euglycemic status will improve the quality. Progesterone, a tricky part. Between 1 and 2 miscarriages, it has not shown to improve any significant, because the body is already producing sufficient amount of progesterone in the body, but overzealous amount of progesterone there. It is the more than 3 where it will have a benefit, and that's the meta-analysis which is available. The problem is the overall, it says the advantage is of progesterone, but you remove the poor quality studies from that, the effect gets nullified. So it is important that not everybody needs progesterone. The higher number of miscarriages will require, not everybody will require. Thrombophilia, it is over-evaluated. People tend to get all those thrombophilic workup, anticardiolipin, IgG, IgM, lupus anticoagulant, homocysteine, antithrombin 3, factor 5 Leiden, beta-glycoprotein, all. Point is, it is a big hoax. And I'm going to come to that. It is an over-evaluation of the patients. The only place where recurrent miscarriage has some value is the acquired thrombophilia. Inherent thrombophilia has a very, very limited value in that. The congenital inherited thrombophilia does not lead to increased recurrent miscarriages. So I think that's one big take home that one should take. It is the acquired one which has a value in recurrent miscarriages, not the one. So checking factor 5 Leiden, homocysteine, protein C, protein S, you will see in lifetime few cases which are raised but will not be associated with recurrent miscarriages. They may be raised but not associated. So keep that in mind, that it is not the test to go for in the first line. Now, you have a whole battery of autoimmune factors now. HLA, cytokines, anti-nuclear, celiac antibodies, all these tests do lipid are available. Intralipid therapies, steroids, these are going to be utilized in a very fraction, less than 0.1% of the people. But we should not waste money on this. And so far, they are all experimental, and there's no data to support that this will work. This is which we don't pay much attention, is the endometritis. A big chunk in Indo-Pak is endometritis. And if bacterial vaginosis. And if you treat bacterial vaginosis, their recurrent pregnancy risks go down. So literature is very clear that if you treat this endometritis, and I'm going to talk about how to go about it in the next few slides. And very simple medications are required, simple antibiotics. Also, endometriosis and adenomyosis, they have some weak evidence, but treating them also a good idea to reduce the risk. So adenomyosis, if it is affecting the cavity, definitely needs to be treated. The diffuse adenomyosis does not need to be operated upon at all. It is the focal or in the posterior wall rectovaginal septum one that need to be treated, must, not the diffuse one, because if you're going to work on the diffuse one, uterus will get lost. It will not get better. Now, this is a simple slide. Our stem cells are floating somewhere here, in this area, in this bracket. So if somebody has done a surgery or curettage which is more extensive, excessive, we have eliminated this. So any kind of a progesterone, any kind of a HCG, any kind of a PRP, any kind of a stem cell will not work until and unless you have preserved this small chunk of the basal layer. With the myometrium, this basal layer need to be there in them before it will act. So all these therapies will work if the basal layer is there. So be gentle on curettage. Try not to do regular DNCs following miscarriages. Use misoprostol or some other medication to eliminate the RPOCs. Any curate is disaster. Using uterine embolization for fibroid also affect the endometrial lining. It takes away the blood supply of the myometrium and kills the endometrium lining. So people will say, हमने फाइब्राइड छोटा कर लिया, डीजनरेशन उसमें हो गई, ठीक हो गया, एंडोमेट्रियम तो उड़ा दी ना. So endometrium का कबाड़ा नहीं होना चाहिए. So be respectful to the endometrium. Then we have environmental, smoking cessation, alcohol reduction, heavy metals ka avoid, plastic ka avoid. These are simple things. The another factor which is psychological. Now data is available that tender loving care, TLC, helps. It improves the quality of life. Randomized controlled trials have been done to see any supportive care, formal emotional care helps. So even there are literature available on meditation that it helps. So beyond the medical domain, all these other comfort care kind of things also do help in the recurrent pregnancy loss. One big area, male factor. Aneuploidy is one other thing which I've been pushing around in Pakistan, but nobody is interested in doing DNA fragmentation test. It is one of the pillar stone of managing subfertility. It is a pillar stone in doing reproductive endocrinology, IVF, or any kind of a treatment. But this is somehow is not touched upon. And there are multiple reasons why people are not interested in that. So if DNA fragmentation is higher, varicocele need to be evaluated, antioxidant will work on them, you can improve the quality, and there is a specific ICSI, which is a hyaluronic acid ICSI that can be done for them. So specific treatment for them. Then there's a big chunk 50 to 75%, which will remain unexplained. In them, there is considered to be a role of progesterone. This is where supplementation has shown to be of importance. So use of progesterone here, PGT is a must in this area, and close monitoring and supporting. So now I'm just going to recap in a few slides. This is our aim, to identify the cause and previous pregnancy loss reasons, to recommend or suggest appropriate treatment, and to help in estimating progress. This is our aim, what we are doing. How we are doing it? The first thing that need to be done in a clinical scenario is the male partner evaluation. In male partner evaluation, a semen analysis must, and if one can do a DNA fragmentation test, is a must sort of a thing. We should push for all the laboratories to start doing it. Anatomical reasons for female, in which the uterine anomalies need to be ruled out because you can fix them. The female physiological part of the hormonal profile, that need to be fixed and evaluated. And last and the least is the immunological one, in which all your anticardiolipins and everything will come in, is the last of the thing. And in male partner, obesity and diabetes history is very important, because this is two important things that will affect. Their thyroid dysfunction will not, because their bodies, in males, the bodies can accommodate the thyroid dysfunction a lot, but in female body it does not. So somehow we need to fix the thyroid in female. In the male, it is not something that is a primary evaluation sort of thing, but obesity and diabetes must be. In ultrasound, if we are talking about recurrent pregnancy loss, 3D scan is of top-notch importance. Top-notch. Dr. Musarrat's role comes in extreme importance here. 2D you can do, yes, but if 3D is the prime thing to go for. Hysterosalpingogram is not going to add much. Hysterosonogram is not going to add much, because you're not, all these things, you're not seeing the outer part of the uterus. You're not able to visualize that with that. So any uterine anomaly which is giving the indentation of the top will not help. Interior cavity, it will. MRI pelvis is not the first thing to go for. 3D will give you the best answer. If 3D is not possible, then MRI can be done. And at this point in time, when doing the scan, these things need to be ruled out. Endometriosis, uterine distortion by any reason. If it is a fibroid, adenomyosis, polyp, septum, anything, if you identify that in the imaging, it needs to be corrected. In the labs, in my clinical practice, I would do a HPLC to rule out thalassemia in all these patients, a ferritin to see whether their hemoglobin has iron deficiency in them, AMH, because low AMH will have higher chances of recurrent miscarriages. So one need to use that in counseling. Prolactin correction is required, so we'll do the prolactin. TSH also. Anti-TPO can be considered, not as a first line, but if you are considering, then it can be considered. Diabetes need to be ruled out. Torch has literally no value in evaluation, no value. So torch need to be placed somewhere outside, not anywhere. Antiphospholipids testing is only done if you have ruled out all the other anatomical and physiological reasons. If any of the factor is there, then there is no need of doing anticardiolipins at this point in time. And these testings are, among all these testing, if recurrent miscarriages are there, filial karyotyping, which is the microarray, parental karyotyping would be done if that is abnormal. ANA testing is now, I'm starting to use it because now we are getting a lot of people with ANA defects, which probably can be helpful in treatment. Again, sperm DNA fragmentation, an important thing that we should have it done. Now, this would be a little tricky and controversial also, that in my practice, and I would prefer doing in recurrent miscarriages, all of them an office hysteroscopy in them to identify any anomaly in the uterus which is correctable, and also one can consider doing a pipple biopsy or endometrial biopsy, because endometritis is a very, very important reason for infections, and doing a pipple in them, taking endometrial biopsy will help evaluate identification of infection and getting it treated. So this is something, and based on that, if that biopsy shows infection, the other things, if somebody wants to go on a higher level of evaluation, then immunohistochemistry can be done, and in which CD138 and MUM1 is available. Not in Pakistan, but in Dubai it is available. One can send it for that. CDC cross-matching, blocking antibodies can be done. And the importance of it is, if it is positive, you close the chapter and forget about any other treatment, because you can't do much now. With negative is the small group of people in which you can help. So differentiating between which can be helped and which cannot be helped is the blocking antigen that will determine this. In very special circumstances, all these tests can be done. I will say. Now, in unexplained RPL, lastly, all these things can potentially work. Using all these strategies, which are very simple strategies, can help us in managing them. There are experimental treatments of steroids in which prednisolone is used, the GSF is used, HCG is used, XCPGT for aneuploidy, and intralipid therapy is getting popular in recurrent pregnancy losses. Our Indian colleagues are using it. They are showing some promise in it, but it is not for everybody. Intravenous immune globulin are being used. Studies are still being evaluating that its effectiveness. Metformin has a good role. We can use it. Sperm selection is another thing that can be done. So overall, the two things which are promising are intralipid therapy and intravenous immunoglobulin. They are potentially promising. And steroids, they do have a role by anti-inflammatory process. So in the end, selective evaluation, husband semen analysis, and if possible, DNA fragmentation. In women, anatomical factors need to be ruled out, treated, and use correction of their PCO, and simple things need to be done. If that is not there, only and only then anticardiolipins need to be evaluated, and inherent thrombophilia is there to be evaluated. Congenital one is not something that we should focus on. That's the take-home message. Thank you.